Welcome to the Nursing Post podcast, All Nursing All the Time with Ashley Moore and Rosa Horsley. Our goal is always to inform, help, and start conversation. And in honor of Pulmonary Hypertension Month, today's episode is on pulmonary arterial hypertension. We're taught in medicine that when you hear hooves, to think of horses and not zebras. Pulmonary hypertension is the zebra of medicine. It can present with vague symptoms and is often overlooked for years. Hopefully today you will learn a little more about pulmonary hypertension and maybe even find a zebra for yourself.
The term pH means high blood pressure in the lungs. This is not to be confused with regular systemic hypertension that's measured with a blood pressure cuff. In pulmonary hypertension, the blood vessels, specifically the blood vessels in the lungs, are affected. They become stiff and narrowed, and they become damaged, which often leads to right-sided heart failure because the right side of the heart is pumping too hard to try to move blood through the lungs. This is very much a topic that is very near and dear to my heart because this is part of what I do.
Yeah, in clinic. And this is Ashley's jam, so I'm just going to let you guys know straight up. Like, this is all Ashley, and this is her jam. Every now and again, I might add a question or my 2 cents, but this is all Ashley.
Yeah, this will be me rattling on and
No.
trying to keep on topic and focused. It's something that I could talk about for hours, and I've become very close with a lot of the patients that have this disease process and really get to know them on a personal level. So it really strikes, a chord with me.
And they love you because every time that I'm checking them in, they're like, where's Ashley? It kind of at first started to hurt my feelings, but now I'm starting to develop a little bit of a rapport with them.
Right.
And I'm like, oh, Ashley will definitely see you before you leave today, but I'm checking you in. I mean, your patients love you.
Well, and I love them. And it's something that I've done for years and have grown with, and it's a very big part of what I do.
Yeah.
So, of course, we like statistics. It's one of those things that we do. So, of course, we'll start this off with a little bit of statistics. We're going to say PAH, and that stands for pulmonary arterial hypertension. But PAH usually affects women between the ages of 30 and 60. Because it is underdiagnosed, we can see patients that are diagnosed later than that. It's not a stiff criteria. It occurs 3 to 5 times more frequently in females than males. There is about 500 to 1,000 new cases each year in the United States. So it is a rare disease.
Wow.
For a breakdown of ethnicity, it says 72.8% are Caucasian, 12.2% African Americans, 8.9% Hispanics, 3.3% Asian or Pacific Islanders, and 2.8 are other. I know that this is a statistic that I have researched, but this is not the case with our own population that I see.
Yeah.
I have more African American women in our PH clinic than anything else.
I find that interesting, specifically because the statistics here are showing opposite. So I don't know if that's just because of our location.
I don't know. It's very intriguing. I've kind of had a lot of conversations because of the demographic in our field that we see in our location. I explained to the receptionist, I'm like, if you get a pulmonary hypertension referral, I'll look at all the referrals. But sometimes it takes them a little bit to get me the referrals. It can be delayed by a couple of days. I explained to them, I'm like, if you get a referral on a young person, I need it right away. And if they're young and Black, I need it like yesterday because of the demographic that we see, because I do want to review it and see if we need to get them in even faster because we want to start treatment as soon as possible. And there's a process to doing that. The mean interval between symptom onset and diagnosis right now, and this is across a whole bunch of different registries, is 18 to 32 months.
Wow.
So there's a delay in treatment for sure, which is why, I'd really try to educate on getting the referrals in, reviewing them, collecting data, stuff like that.
I mean, because that's over 2 years. 32 months is over 2 years.
Yeah.
So some of the signs and symptoms with persons or patients having pulmonary arterial hypertension are shortness of breath following exertion. So you tend to become short of breath just walking a short distance. And I know in our clinic, we do the 6-minute walks very often on them, just to prove the shortness of breath with exertion and how to treat it. Excessive fatigue, weakness, chest pain, dizzy spells, and syncope, which means fainting.
Right.
There's also causes and risk factors that increase your likelihood to have pulmonary or arterial hypertension. It being idiopathic, heritable, which means, that's genetic through your family.
Right.
Drug and toxin induced. So I think here we're talking your amphetamines, fen-phen. It's also been associated with connective tissue diseases, HIV infection, and portal hypertension. Sometimes you're born with a congenital heart disorder or disease, and cystostomosis. I do not know what that is.
Yeah, we don't see it a lot here in the United States. It's more prevalent in other countries. Mm-hmm.
And persistent pulmonary hypertension of the newborn.
Right.
So I didn't know that newborn babies are susceptible to pulmonary arterial hypertension.
Yeah,
That's
a lot of that.
Right.
A lot of that happens because of the congenital defects.
Okay. That's interesting.
Thank goodness. I don't think, as much as I love PH, I don't know that I could work with kids with PH because it's hard enough for me to work with adults.
Oh, yeah.
And I do get attached to my patients.
You do.
So that was kind of one of those things where I was like, yeah, I can do this as long as we never deal with kids.
Oh. Well, in our area, where
and my
would they
doctor,
go?
They would go to...
Because if our clinic's not seeing them, they have to be seen somewhere.
Right. And we do try to refer to other accredited centers just because we know that they're going to get proper care. We did have a young female who was pregnant, and we don't manage that.
Wow.
So we did have her go to an academic center.
Wow.
It's about an hour and a half away.
Yeah. And
have them manage her care during her pregnancy. And then when she was finished and she had the child and, things had gone back to what I would consider normal, then she came back and we picked up her care. There was constant conversation between that doctor and the doctor that I work with to make sure that we were all on the same page, because you really do get to know your patients inside and out. Mm-hmm. You can say a name of many of my PH patients, and I can tell you by heart, their history,
front and back of your
hand, their medicines, what they need, their last visit. So
when they say I'm taking a blue and a yellow pill or an orange and a green pill, I'm like, Ashley, I don't know what pill this lady's on, but I know you know every color.
Yeah. Yeah. Well, and the color coding helps.
It helps the patients. I'm not going to lie.
It really does.
It doesn't help me, but it helps the patients.
There are what we consider WHO groups. It's how we categorize the reason why you have pulmonary hypertension. It's broken into 5 groups, and there are subcategories in each one of those groups. So the easiest way to try to explain this is you treat patients who have pulmonary arterial hypertension who fall into group 1 and group 4 with these specialty medicines. Group 1 was what Rosa just went over pretty much. And group 4 is from what we call CTEPH, which is chronic thromboembolic pulmonary hypertension, which is just chronic clots in the lungs. This may or may not have occurred in the setting of an acute pulmonary embolism. So you can have this disease and never have had an acute pulmonary embolism. The other groups, there's a group 2, which is mainly due to cardiac involvement for the left side of the heart. Like they have diastolic heart failure, things like that. Group 3 is anything dealing really with the lungs, like COPD, interstitial lung disease. There's a whole list, but that's pretty much falls into 3 is for your lung conditions, and sleep apnea fall into group 3.
Okay.
And then the 5th one is just your mixed bag of people who get pulmonary hypertension, and we know it's associated, but we don't have either enough research, or the research that we have has shown that these special medications that we use to treat it are not effective. So there is a list of diagnostic criteria that we do for patients with pulmonary hypertension, and that's because it's really a disease of exclusion. So if you don't have any other reasons for this elevated pulmonary pressure, then you have pulmonary hypertension that we're going to treat. So we have to rule out all your lung disease, all your heart disease, all these little mixed bag things we have to go through. It's like a whole list, and
that's a lot of labs being ordered.
Mm-hmm.
There's a lot of, imaging being ordered.
Yes.
A lot of cardiac testing that's being ordered. And I know you'll break that down a little further.
Yeah.
But I know in our clinic, there's a lot.
Yeah. So most of the time patients come to us once they've had an echo, and the echo estimates pulmonary pressures. And then it also, of course, shows you, the ventricles and how well they're functioning. And when you have somebody that has high pulmonary pressures and a dilated right ventricle, that's a problem. Because if you think back to kind of nursing school, the right side of the heart is not as robust as the left side of the heart. It's kind of finicky, doesn't really have a lot of give. So that's really normally what brings them to us for an outpatient referral. And if they haven't had one recently, they're getting another one. Labs, if you have a hyperactive thyroid, that can induce pulmonary hypertension. And if you fix that, it'll go away. So it's really important to do a thyroid test. We do like an autoimmune workup, ANA, stuff like that. We do check for HIV because we know that HIV is an associated reason to have pulmonary hypertension. And we do basic, CBCs, chemistries, BMPs. A lot of nurses will see BMPs that can be in the thousands, and they really don't flinch at it. And that's fine for left-sided heart failure. But if you have an elevated BMP, you don't have left-sided heart failure, you have right-sided heart failure. If you just get up in the mid hundreds, we start getting anxious. Okay. So it's not, you have to understand what you're looking at there. Of course, like you said, the pulmonary function test. A lot of the patients who we see that have pulmonary hypertension, they'll have normal pulmonary function tests, but their DLCO will be low because the disease affects the vessels in the lungs, and that's what the DLCO is working with. CT scans, VQ scans, chest x-rays, those are looking for those clots or any underlying lung disease. You can do EKGs because, of course, we can get a good feel if there's any other underlying cardiac issues. The 6-minute walk, that gives us our functional status. And then the gold standard to know is the right-sided cardiac cath. That tells us.
Our clinic does a lot of those.
Yes. Well, yes. You should.
I think they do.
Every patient that we're treating for pulmonary hypertension has had a cardiac cath and will get, I hate to say routine, but it kind of is. We have to kind of keep up with it. And this is a progressive disease. So that's how we really know what's going on. The echo is a great tool for screening that is non-invasive. I went to a seminar once and a lady explained it. You can look at a tire on your car and you can tell that it's low. You can feel it, but you don't really know how low it is until you get the right tool and you put the tire gauge on the tire, and then you actually get an exact number. That's the difference between an echo and a cath.
Okay.
So the cath gives us the exact numbers that we need to know that we're treating the right disease process.
How invasive is it? Like, what are the instructions that you tell your patients? What should they hold? Are they NPO the night before? Like, what are the instructions that you would give to your patient that's getting ready to have a right heart cath?
We do tell them to not have anything to eat or drink after midnight. We do not really get them to hold a lot of their medicines because it can affect the results, especially if they're already on medication for pulmonary hypertension. They absolutely do not hold that. Fluid pills, some people say, well, they need to hold it, but if that's their baseline, a lot of times we don't get them to hold those either. Like, they kind of go in, they take their normal medicines with a sip of water and then go in.
Like, what about if they're like on aspirin or Coumadin or Pradaxa or something like that? Do they hold that?
No.
Okay.
We do get an INR checked a couple of days beforehand, as long as they're within their therapeutic range, which is usually 2 to 3 for whatever reason they're on Coumadin for. We get them to stay on it. We don't actually get them to hold it.
I didn't know that, and that's why I was asking, because I think, for most surgeries or procedures, you hear people say hold, your vitamins, hold your blood thinners.
Right.
So with this, you don't do that.
No. The only time I would get them to hold their Coumadin is if they're obviously if their INR was really elevated.
Yeah.
And then, of course, we check it that morning. They do labs that morning when they get there, your basics, your chemistries, your blood counts, things like that. And the reason that you do the cath and the reason why I call that the gold standard is because in order to be diagnosed with pulmonary arterial hypertension, there are certain hemodynamics that you have to meet. That's part of the definition of having the disease. And that means a mean PA pressure 25 or greater, a wedge pressure of 15 or less, and a pulmonary vascular resistance of 3 or greater. There, at the last conference I went to, there was some talk about those numbers being altered, but I don't think that that's gone all the way through yet. So, I mean, it is something, it's an entire workup. And I tell patients, it's a lot.
Well, medicine is that anyway. You're ruling things out before you can pinpoint a diagnosis. That's why they call it a differential. But,
right.
I mean, there's a lot there that you have to go through. You have to test your lungs. You have to test your blood work. You're talking about your lungs and your heart. So if I were that patient, I would want you to rule everything else out.
Right. Well, and the thing of it is if you treat a patient, let's say we didn't rule out the left side of heart failure, which I don't even know how that would even happen, to be honest. But say this person has diastolic heart failure and you give them medicine to open up the blood vessels in their lungs. All that blood is all of a sudden going to not have that resistance, and it's going to dump all this blood, which is essentially fluid, into the left side heart.
It's just going to sit there,
not functioning properly. And then that's a problem.
Yeah, of course it is. It can't pump to the rest of your body like it's supposed to do and keep you oxygenated and everything
that can
else.
Cause pulmonary edema. That's a hospitalization waiting to happen. And so you don't want to just put somebody on medicines to treat this without going through that list and being very careful, because if you treat the wrong person, you can make them worse.
Absolutely. And some of these medications and stuff that you're probably getting ready to talk about, because I know the treatments are next, but a lot of these medications, they also have side effects. And if you're treating somebody who doesn't have this, they're going to end up with something different. Another problem.
Without a doubt. And I'm going to tell you, you have the person on the right medicine. I went to the grocery store the other day. One of our patients so happens to work there. And she had stopped me and she was telling me about some of the side effects that she was having. Her next statement was, I feel so much better with my breathing that I'll deal with the side effects. That's how you know you have the right person on that medicine.
That's true. And like we always do, we always try to weigh the benefit and the risk.
Right. And she's like, I'll take, I have a headache. And I'm like, well, look, if you're always getting a headache at your second dose, then make sure then that
Taking
you are pre-treating before you take that dose, and that you're doing these things, and we kind of had a conversation
in the middle of the store,
in the middle of the grocery store. It's kind of one of those things with when you love what you do, it's just fine. And my husband's like, what took you so long? I was like,
work stuff.
I ran into somebody.
Work.
And then it just keeps going from there.
But that's why your patients love you so much. They have that trust, in that relationship and in that rapport that you've built with them, because you are very knowledgeable and educated in this particular, disease process. So they know that if they ask you a question, they're getting a truthful, honest answer. And if you don't know the answer, that you're going to find it out and that you're going to give it to them. And that's how all nurses should be with all disease processes, with all their patients.
I agree. And I think it's the difference in finding something that you really like doing
about,
versus going through the motions. It does make a big difference. And a lot of these patients are just so appreciative to find somebody who didn't think they were crazy and that was willing to help them. We had a patient came to us probably about 4 years ago, and her life, to say was in shambles is an understatement. I remember the first day I met her, I was talking to her. I had looked at her paperwork, of course, because I look at the referrals before they come in to try to gather as much information, because the more we have, the more productive that first visit is. And I remember the doctor coming out to me and he's like, yeah, she's definitely got the real deal. We'll do these couple of things to wrap up workup, and this is what I want to go ahead and do. And so we did that, and it took about 6 weeks to go through all the scheduling, getting results back, getting her started on medicine, which is really not bad because I mean, that was probably, she came in, she saw us, we ordered all these tests, she came back, she went over results, we initiated medicine, and she was on therapy within about 6 weeks.
That's actually pretty decent.
Yeah, because I'm thinking that it probably took about 4 weeks just to get all the diagnostic stuff done. And she wasn't like in an acute place where she was really bad off, but she was in a place where her kids thought she was crazy. Her husband left her because he thought she was crazy. She had been having complaints for about 2.5 years. And the last doctor sent her to a psychiatrist.
Wow.
And I remember looking at her paperwork, and when she was telling me that, and I had talked to the doctor, I was like, her doctor sent her to a psychiatrist. And he's like,
he was probably
really?
thinking she was a hypochondriac, and that's why, she was referred, but there was something wrong the whole entire time.
There was. And he's like, did you look at this? Did you look at her paperwork? This is impressive. And I was like, yeah, I did. And he's like, this is going to be an awesome visit, because he knew from doing it for years and years and years. He's like, oh, this is going to be like somebody that we can help. And when she came back in after being on medicine for about 2 weeks, she cried. She's like, I can breathe. And I was like, yeah. And she's like, and you guys believed me. Fast forward 4 years later, her kids, feel like
crap.
Who, but those relationships are mended, and she's back with her husband. And so to really sit there and think about that, I'm like, man, her husband left her thinking she was crazy. But what would I think if the person that I was with went to all these doctors? They're all telling her nothing's wrong. They're sending her to a psychiatrist. You tend to believe those providers.
Well, you tend to think as a layman person that doctors are more educated, that they know what they're doing. But you and I know, before doing this podcast, and as we've been doing it, and we've learned so much while doing it, that you have to have a good rapport with your physician.
Absolutely.
And if your physician is not listening to you, that's not the right physician for you.
Right.
And had she had that right physician to begin with, her process wouldn't have been as difficult as it was.
Right. And the only reason that she was even referred to see us was because she asked to be referred because she couldn't breathe. And she's like, well, let me at least see a lung doctor. And if the lung doctor says that there's nothing wrong with my lungs, then I'll go to the psychiatrist and figure out, what my crazy is about. And I just sat there, and we've become very good, I want to say friends, but if she needs anything, she's always just like, Ashley, I know I can call you and you'll help me. And she walks in doing fantastic. And she's just like, I'm going to be forever grateful for everything that you guys have done and for believing me. And I know that her husband has come in and said, I can't tell you what it's like to have my wife back, because this is the way she used to be. She was, of course, when she came to see us, she was depressed. She was in a bad situation. She was pretty much losing her entire family and her support. And now all that's kind of brought itself back together. And, you never want to tell somebody that they have this disease. I mean, it's not a good disease to have. The outcomes are better than they used to be, but they're still not great. And it's constant research going on. But I mean, you're looking at a 10-year lifespan for a lot of people who are diagnosed with this.
In her situation, when a patient's consistently being told there's nothing wrong with you, there's nothing wrong with you, there's nothing wrong with you, and then to have somebody sit down and validate that there is something wrong with you, it's not you're happy to have something wrong. It's just happy to have somebody finally tell you what the issue is and how to go about solving it. Nobody wants bad news, but I tell you what, in this case in medicine, sometimes no news is not good news.
Right.
Like in her case, she kept getting told, no, there's nothing wrong, but there was. So kudos to her for being like a very, very big advocate for herself.
Exactly.
And not letting it go, because that's the most important thing as a patient And as a nurse, me telling my patients are like, listen, you are your best advocate. Nobody is going to fight harder for you than you.
Exactly.
And that's exactly what she did. So kudos for her for not giving up.
Absolutely. And this case is not a special case.
Oh, it
I go to
happens a lot.
conference after conference and talk to patients who are at those same conferences. It happens all the time. And it's so sad because everybody's just, if they don't understand something, automatically the patient's crazy.
Mm-hmm.
That's not always the case. And I think it's really important that we give patients the benefit of the doubt that they do know themselves and they do know their bodies. So to talk a little bit about the medications to treat pulmonary hypertension work really on 3 different pathways. They kind of go into 3 different categories. The first category I want to talk about is a PDE5 inhibitor. It's, I guess, the cheapest treatment options.
Is it like generic?
Some are generic. They're called sildenafil, tadalafil, and the other one is branded as Adempas.
Well, I'm only familiar with the sildenafil because I was a urology nurse. So I know its function and its purpose is to open your blood vessels to increase blood flow.
Right. So sildenafil is Viagra. Tadalafil is Cialis,
which I'm familiar with as well.
And they are the cheapest. Right now, sildenafil, a lot of our patients, if the insurance company won't pay for them, we give them a good RX and it's like $15 a month.
No, that's not bad.
So that's good.
All.
That's your best bet. And then the next medicine is tadalafil. That is a little bit more expensive. You're looking at $1,000 to $3,000 a month. That's the cash price.
Because unlike urology, like they're having to take it every single day.
Yeah, that would be 2 tablets a day. The sildenafil is 3 tablets a day. And so the tadalafil is a little bit more expensive. And then the last part of it is the Adempas, and that is a titrated medication. Adempas is actually specifically for CTEPH, but also can be used in WHO Group 1 patients who have like a connective tissue, HIV, congenital heart, idiopathic, all those patients. They can also use that as a first-line medicine. We don't use it that much as a first-line medicine. There's a big cost difference for our patients with the Adempas that is close to, $80,000 a year versus sildenafil, that's $15,000.
That's a big difference.
And so we really do think about our patients who need to not only be on this medicine, but they're also on other medicines as well, because a lot of our patients have comorbidities. Those are PDE5s. They're very well tolerated. There's not a lot of side effects. The main side effect that I hear is headache. That typically goes away on its own once your body kind of adjusts. There's a couple other little side effects, but not really. It can cause a drop in blood pressure. All of these can, because we are dilating the vessels in the lungs. And in order to do that, it drops the blood pressure. And so there are times where we have to actually like pull back on systemic blood pressure medicines to compensate.
Makes sense.
So that of course does happen. The PDE5s work on the nitric oxide pathway. So that's how they are helpful. Another category is what I call an ETRA. It's an endothelial receptor agonist. There are a couple of different medicines as well for these. They are all more expensive than the last one. So this group is even more expensive. They work a little bit differently. Each one of these do. So to explain, it works on the endothelial pathway. So that kind of goes together. But the ET1 is a very potent vasoconstrictor. Okay. So that tightens vessels and it has a proliferative effect on vascular and smooth muscles, which just means it destroys it. And this is the best way I know to explain it. And so what we want to do is stop that from happening. We don't want to destroy the vessels. We want to keep them intact and functioning as properly as we can. There's a selective and a non-selective ETRA that are approved. Theoretically, the selective ones should be more effective than the non-selective because it kind of works in 2 different ways. But there have has not been any trials to actually prove that. That's just a theory. So the first one of these that came out was something called bosentan or Tracleer. And it is a non-selective medicine, and it's been used for, the last decade. The downfall of this medicine is it does require monthly liver function testing because it can affect the liver. And I've seen this happen. So it's not one of those things that rarely happen. At a smaller center, and I've seen it happen several times. They also have to have pregnancy testing if the woman's in childbearing age. Being on birth control does not count. IUDs does not count.
People have still gotten pregnant with all those things.
If you have a uterus and you can get pregnant, you have to have monthly testing. Mm-hmm. Even if you say, no, I'm not sexually active. Sorry. Still
One
have
night
to have
you
it.
could have been.
Right. So and all of these medicines, you have to have monthly pregnancy testing. The next medicine is ambrisentan or Letairis. That is a selective ETRA, and it doesn't have as much hepatic injury as the Tracleer does. So it doesn't really require monthly LFTs, but it does require that you monitor them.
Every 3 months? Is this the one that's every 3 months?
About every 3 months. It's really the provider discretion, but I know, depending upon how often we're seeing the patient, how long they've been on the medicine for, when we first put them on it, we're checking it a little bit more regularly than as time goes on, but we're still checking it pretty regularly. And then the last one is macitentan. That's also Opsumit. That's the newest one. It is kind of a dual kind of medicine, an ETA and an ETB, and it works the same way as the other medicines do. It's labeled that it doesn't need the LFT monitoring. We still do. It's kind of part of a Chem 12 anyways. Mm-hmm. So you kind of get,
might as well do it.
You kind of get both bang for your buck with that.
Yeah.
But you do have to watch for anemia with this one. And the last set of medicines that I want to talk about is prostacyclins. These come in oral, inhaled, sub-Q, and IV. And it kind of stacks up. These are hundreds or $100,000 plus a year. Some of them are capped at how much that they charge. Like it's going to be $120,000 a year, no matter how much medicine they're on. Other medicines, as the dose goes up, so does the price. So
yeah, that makes sense.
There's a lot of opinions of that, of course. But Ibraposinol, it was one of the first medicines that came out years ago. And this is used through an indwelling hone catheter. Mm-hmm. And it's a constant infusion. The patients have to be able to be very meticulous with their site, of course. It does require refrigeration and ice packs.
Wow.
So patients have almost like a fanny pack or a little purse, and the pump is in there, and then they have it surrounded with ice packs.
Wow.
That was the first medicine to come out to treat this disease, and was the only one for a while. I think in the last 10 to 15 years, they've come out with 14 new medications. So when I say research is constantly being done on this and improved, it really is. The next one that I want to talk about is Tropostenol, and it has, actually I want to go back. Another thing with Ibraposinol is the half-life on it is under 5 minutes. So as soon as that medicine stops, you're in a pickle because you can have rebound disease. You can't just stop that medicine. Like if the patient was to rip out their line, that's like, I need to go to the emergency room and somebody needs to start a peripheral and get this medicine infusing like yesterday.
Wow.
It's used, I think, more in the hospital settings than it is in the outpatient. Mm-hmm. And because our catchment area for the patients that we see is pretty big, and not everybody lives within 5 minutes of the hospital, and some people we have that travel 2 hours to see us, we do not prescribe this medicine really at all, just because it requires a refrigeration. The half-life is so short on it. It is used in our hospital though. The Tropostenol is another medicine. Now this one comes in oral, it comes in inhaled, sub-Q, and IV. It has a greater half-life. It has up to 4 hours. So you can see why we would like that for our big catchment area, because it's a little bit more time if there's a problem that you can get to the hospital. It's probably, I would say, one of our most used medicines, just because of the sub-Q. It comes in and the oral and the inhaled, and you can transition from one to the next easier because it's the same chemical.
I think compliance with this type of medication compared to the previous one with patients, like this treatment would probably give a patient more compliance or ability to be compliant with their medication.
Yes. When you stick a line in somebody and tell them that this line is there to save your life, it wakes them up. And there's a lot of socioeconomic things that you have to think about before you just stick a line in somebody. It's not like, okay, you have the disease, it's pretty bad. We got you on these therapies, we need to add one more, we're going to put a line in you. No, I mean, if somebody has this disease because of, their, IV drug use and HIV, you really don't want to put a line in them.
That person, absolutely.
But what's nice about this is you do have orals. It does take a little bit of time to titrate up on because there are side effects. A lot of people with the orals have a lot of GI complaints. And then with the inhaled, I don't hear a lot of complaints about that necessarily, but they can have like issues with cough. The sub-Q burns like a branding iron when they change it and have to infuse it, and they have to change their site every couple of weeks. And every time they change their site, they have that new like branding iron burning pain that's not really relieved by anything. I mean, we have some patients, they tolerate it very well and just use like different combinations of therapies that we have them on. But then we have some people that are on narcotics and still dread changing their site. But they'd rather do that than have a line. And that's kind of, again, you have patients who are willing to deal with this because of the benefit that they get from it. And there's a lot that goes into picking these different medicines and what you can do. And it does take a lot of teaching, a lot of thought to if the patient's going to do it, will they put up with everything? All the side effects. Like some patients are just a lot easier going. They're like, yeah, it hurts, but I understand it's what I have to do. And there's some people who's like, I'm just not doing it. I'd rather die. I'm not going to do it. There's Ibraprost, which is just like Ibraposinol, except for it's stable. It doesn't have to be refrigerated. It also comes in an inhaled form. We don't use it as much because that inhaled form, you have to do 6 to 9 times a day versus the prior one was only 4 times a day.
Wow. Yeah.
So there's a lot of differences there. And there's another one that is Selexipag, that is a oral medication. It's pretty well tolerated. All of the prostacyclins can have issues with headache, actually jaw pain, and that's usually when they take their first bite of food at a meal. I know it's weird, but nausea, like the stomach upset, nausea or diarrhea, and it also can just cause like some rhinitis. Like a lot of people have like nasal congestion or a runny nose. And it's just because we're dilating everything. Yeah. Like all of these medicines all work to just dilate the vessels that are in your lungs. So that way the blood can flow easier through the way the blood flows through your heart, how it pumps through your heart. So, if it goes into the right atrium, to the right ventricle, and then it goes to your lungs. And if it can't go through your lungs easily, it backs up and it backs up into that right ventricle. So that's why the right side of the heart gets the brunt of it. So if you open up those blood vessels, then all of a sudden the right side of the heart is happier because it's not getting that backflow like, oh, this blood's coming in, but I can't push it through the lungs. And so there you go. There is a little reprieve for the patients who actually have what we call a positive vasodilator challenge. It's part of the right heart cath where they can put something like nitric oxide. There's other options that you can use where the patient takes a medicine or breathes a medicine in to see if it lowers the pulmonary pressures. There's, parameters that have to be met to be considered a responder. But if a patient is a responder, then their first line of therapy is actually just a calcium channel blocker.
Okay.
But I don't think we don't have one patient who's a responder that's just sitting on a calcium channel blocker and hasn't gone up and got on other of, more specialized medicines.
Well, you did mention that a lot of these medications are super expensive.
Yes.
And I know I personally don't have $80,000 on hand to just hand over in medication costs.
Right.
I don't know very many people that do, that
Right.
just have that sitting aside every single year for medication purposes.
Well, and that's just one medicine. So if you're on all three, think of that's like $300,000 worth of medicine. 250, 300,000.
If you're not the 1%, how do you pay for these medications?
Your insurance company will pay for part of them. If it's infused, whether it's through IV or sub-Q or inhaled, your medical benefits will pay for part of that. If it's a pill that you take, your pharmacy benefits will pay for a portion of it. It still leaves a hefty copay, because if they go, okay, we'll pay 80% of your specialty drug. Okay, that's fabulous. But
unless you're talking about 20% of 80,000.
Exactly. And so at that point, these medicines come from specialty pharmacies, and there are specific foundations that help patients who have pulmonary hypertension, which is a rare disease, and they actually give them grants for copay assistance. And what happens is you just apply for the grant. They give you like a insurance card information. They tell you this is your ID, this is your PCN, BIN, group number. Give that to the specialty pharmacy, and the specialty pharmacy then, after they run your insurance and it brings the cost down, say one of the medicines, the copay is about $1,500 a month. Now, that's a lot better than $7,000, but still a little unattainable.
Still hefty.
And then that's when they go, okay, you have a $20,000 grant, so we'll subtract the $1,500 from your $20,000 grant, so now your copay is $0. And that's what happens for a lot of our Medicare patients. If you're like dual enroll Medicare, Medicaid, your medicines are usually covered at no cost.
Awesome.
If you are in a low socioeconomic status, then you can apply for what we call as extra help. And your max you'll pay for a specialty drug is it was $8.40. That may have changed, but it's less than $10 a month. That's doable.
And $1,500. So even then, that's swingable.
Right. And then the other one is for patients who are commercially insured. There's a lot of copay cards that bring the medicine down to $5 or $10. So I tell patients, if you pay more than about $25 a month for any of your medicines, you need to talk to me. I tell patients every time they come in, I'm like, well, how much is your copay? And some of them, I think, were very offended at first. Why
are you asking me about my money? I'm sure you got a lot of those looks.
I did. And now they call and they're like, I had that one lady, she ended up paying $1,000 for her medicine. It was her entire Social Security check.
Oh my gosh.
And I'm like I start getting heart palpitations. I'm like, why didn't you call me? Why didn't you call me? And she's like, well, I talked to you so much. I didn't want to bother you. And I'm like, don't ever pay that much money. So I did a lot of digging and a lot of work to find out that she actually was enrolled in a grant. She didn't even realize it.
Oh my gosh.
Somebody had helped her get set up for it. And so I'm like, please, Lord, let me be able to backdate and get her money back. And so after a couple of hours of on the phone and talking with people, I found out that she was eligible and it could be backdated. It was going to take her sending in her receipt with the date on it of how much she paid. And then they would cut her a check from the foundation directly, because that's what they had to do, because the pharmacy was kind of out of the equation about them. And so I called her and I'm like, okay, do you still have the receipt? She's like, oh yeah. I'm like, okay.
She was going to put that on her taxes, I'm sure.
I'll put it somewhere. And I'm like, I want you to go make a copy of the receipt and I want you to mail it to this address and they will cut you a check for that amount of money because you were under a grant. And that's actually happened a couple of times where we've just really gotten lucky where the patients just didn't quite understand the process, especially if they're new. And I explain the process over and over and over and over again, but it's a lot of information for people who who are getting a new diagnosis, and then they go home and Google it, and it's like, oh my God, I'm going to die. I'm going to die tomorrow, because that's what happens when you Google this. It's automatically bad. If you're going to Google, this is where we would like for you to go on the internet. Like, we provide that information, but patients still just Google it. And now, of course, most of my patients call if their bill starts creeping up, or they get a high, like, oh, all of a sudden I have this high copay, what's going on? And I just have to do some digging to help them out, because they just don't know the ins and outs of it.
That's a lot of work. I don't think patients realize how much work it is on the back end, doing the prior auths, filling out the paperwork for grants, trying to contact them and say, hey, I need your financials. I need you to come in and sign this piece of paper. I need your permission to do this. I don't think they realize the amount of work, even just making phone calls and being on the phone. I know I've seen you be on the phone 30, 45 minutes, half of that time on hold, just to speak to a live person.
Right.
It's a lot of time that goes into it. So
for
I know
sure.
your patients are very appreciative of it, but I just don't think most patients realize how much work goes into it.
No, they really don't. I mean, I'm in a constant contact, because what I do is strictly outpatient. I do not do any inpatient stuff. So if the patient's in the hospital, there's another person. I say there's a me over at the hospital, and she says there's a me over at the office. But we are in constant communication between our group, our team, that a lot of them laugh, because they'll call me her name, and she'll walk in and she was like, hey, I'm such and such, I'm Ashley over here, and so that they understand what her role is and what my role is. And she will call me and say, hey, I have a problem with this going on with this patient. They're new. And, there's a lot of times, if for some reason she's not at the hospital, that I will actually go to the hospital, sit down, talk with the patients, explain a lot of the stuff, because the doctor that I work with is wonderful. He's wonderful. He's a great physician.
He is.
He's a very smart man.
Very much.
He forgets to tell them that this medicine's $80,000 a year. So I'm always the bearer of bad news. I'm like, you got to tell them this. Like, they have to have a minute to process it. And he's like, oh, I don't even think about it, because none of our patients pay that.
Yeah,
like, you get everybody covered, and it's never an issue. And I'm like, well, yeah, I know. But when they first hear from the pharmacy, and if we haven't had a chance to get all the grant stuff straight, then they are like smacked with this huge number of thousands of dollars for their copay. And they're like, well, if that's my copay, how much is the medicine? And they're like, oh, it's on $94,000. And they're like, what? Huh?
I can't afford that.
I'm gonna die. Yeah. So it's a lot of constant communication, and it's a lot of teamwork. It's something that I love to do, but it's really hard to raise awareness about this. I have so many people that take years and years and years to get diagnosed. And if it's kind of like cancer, the sooner you catch it and treat it, the better it is, because our goal is to make the right side of your heart strong, like the left side. And inherently it's not. So what we're trying to do with these medicines is really beef up the right side of the heart, so we can actually take that pounding, and a lot of the patients that, if they're in the hospital, and that's where our referral comes from, they're in right heart failure and on their deathbed.
They're in bad shape if you're getting referrals from the hospital.
It's just, for sure, a process of just trying to raise awareness to say, hey, if you have somebody that's coming to you and they're complaining of shortness of breath, and they have, a history of meth abuse or HIV, there's even a link with a medicine called Sprycel. It's actually a chemotherapy drug that can induce pulmonary hypertension. Autoimmune diseases like scleroderma or mixed connective tissue disease, We talked about HIV infection, patients who have portal hypertension
Mm-hmm.
from liver disease or congenital heart, all those things, if they're complaining of a lot of shortness of breath and you do an echo and you see that their PA pressures are elevated and their right ventricle is dilated, like that needs to be taken seriously because
ABC.
exactly.
ABC of nursing.
Right.
Raising awareness around this rare disease is key. It's key to patients being diagnosed sooner and being treated faster. We need to work harder to lower the average of 2 years. That's a pretty long time. And like with all and anything related to medicine, the sooner the treatment begins, the better the outcomes for the patients are. So, as always, we will link our references on our website, www.thenursingpostpodcast.com. We would love for you to join the conversation by leaving comments and suggestions. And we would love for you to subscribe to our podcast, whether that be through the website or on your favorite listening platform. You can also follow us on social media. Thanks again for listening to the Nursing Post podcast.